Welcome to the third module in the Geneva Foundation for Medical Education and Research, World Health Organization, Eastern Mediterranean Regional Office, Joint Adolescent Sexual and Reproductive Health course for 2021. This module is titled Antenatal Care, Intrapartum Care, and Postnatal Care. My name is Chandra-Mouli, and I work on adolescent sexual and reproductive health in WHO's Department of Sexual and Reproductive Health and Research in WHO headquarters. I will present a global overview on this subject, and then following that, my colleague J Al-Raiby, who works for WHO EMRO, will introduce herself and then present a regional overview. This slide contains definitions for three key terms: antenatal care, intrapartum care, and postnatal care. The objectives of all three are to ensure the best health conditions for both mother and baby through the provision of skilled health care by trained and supported and well-equipped healthcare professionals. Antenatal care is provided during pregnancy, intrapartum care is during childbirth, and postnatal care is up to 6 weeks following childbirth. This slide is one of two slides which provide a rationale for investment in antenatal care, intrapartum care, and postnatal care. It makes 2 points. The first is that in many contexts, adolescent pregnancies are common. The slide presents data in the 15 to 19 age group, which is the data that is generally recorded in large-scale surveys and in statistics gathered at the country level. But it also gives estimates of births below the age of 16. The second point it makes is that adverse maternal health outcomes among adolescents have major health and social consequences. So pregnancy and childbirth related complications are a leading cause of death in girls among 15 to 19. And babies born to adolescent mothers have an increased risk of both mortality and morbidity. So there's sound rationale for investment in this area. In the previous slide, we talked about the fact that there is a need. Adolescent pregnancies and childbearing are common, and they have serious consequences. Health consequences, we didn't touch on social consequences, but it has social consequences too. Loss of opportunities to study, to work, and to grow and develop. This slide focuses on two other points. One is that there's convincing evidence at the research level and from the programmatic experience level that antenatal care, intrapartum care, and postnatal care are effective. They can improve health outcomes for mothers and babies. And two, both access and quality of care need attention. In some places, adolescents face barriers to accessing and using skilled care before, during, and after pregnancy. And we'll see statistics from globally and from the region later in this presentation. And then secondly, there are groups of adolescents, very young adolescents, unmarried adolescents, and those who are displaced because of humanitarian conditions, who have difficulties in obtaining access. And in 2020 and now extending into 2021, we have the huge problem of COVID-19 and the disruption that it has caused and the effect of this on all services, including maternal health services. The next two slides contain global data on access to care in two areas. So this slide contains data on a percentage of adolescent girls aged 15 to 19 attended by a service provider at least 4 times during pregnancy. And this data is global and is for the period 2013 to 2018. So globally, the estimate is 56%, and there has been progress in the Millennium Development Goals period, that's 2000 and 2015, and in the 5 years of the Sustainable Development Goals period. And of course, as you can see in this slide, there's unevenness with some parts of the world being left behind. And that's particularly true in sub-Saharan Africa and Southeast Asia, as well as certain countries of the Eastern Mediterranean region. What is important is that global and regional data, as well as country-level data, hide inequities at the subnational level, and that needs to be taken into account. This slide contains data on the percentage of births among adolescent mothers attended by skilled health personnel by country and for the period 2013 to 2018. Again, in the last 20 years, there's been steady progress and sometimes fairly dramatic progress on this indicator, which was a huge priority during the Millennium Development Goals era. And what you see here is an overall estimate of 76%. That still means that 1 in 4 women of this age group do not have access to skilled care. So there's an unfinished agenda, but it also points to the huge regional variations and country variations, as well as I said earlier, what you don't see in this slide are the variations at the subnational level, are the inequities at the subnational level. This slide stresses that states are obliged under human rights law to provide maternal health services, and upholding adolescents' rights in this area is linked to state obligations to ensure universal access to a comprehensive package of sexual and reproductive health interventions before, during, and after pregnancy to all women and girls. On the basis of human rights and human rights obligations, maternal health care should be free, confidential, adolescent responsive, and non-discriminatory. And further, third-party authorization requirements should be removed. This slide contains two concepts. One is that pregnant adolescents, especially unmarried ones, often face barriers to accessing maternal health services. And as I said earlier, while this is particularly true for unmarried adolescents, it is also true for married adolescents who belong to marginalized groups. And in the context of COVID-19 and the humanitarian crises which affect many countries of the Eastern Mediterranean region, but also occur elsewhere, access is affected for all segments of the population, including adolescents. The second point is that maternal health services are often not responsive to the needs of adolescents. They are not responsive, they are not sensitive to the needs of adolescents, and as we will see in some of the background papers that you will be provided, adolescents, particularly younger adolescents, and those with less education and are much more likely to be mistreated. So it's not just a lack of responsiveness and sensitivity, it is also a problem of increased likelihood of mistreatment and abuse in this age group. This slide lists WHO guidelines in this area. This is a rich body of work. All these guidelines are available on WHO's website and are available on request through the Geneva Foundation for Medical Education and Research. I'd like to stress that these WHO guidelines are available online openly and without charge for anyone who requires them. Now, guidelines are the flagship documents of WHO. They contain evidence-based recommendations for research and for practice, which are based through a very careful scientific process. In addition to guidelines, there are other documents produced both by WHO, such as program support tools, but also by other organizations. And one example is the ASRH Toolkit for Humanitarian Settings that has just been published. So again, these documents are listed, and all of them are available on the website of WHO or the other organizations which have published them, or are available on request. One of the documents that we have included in the list of complementary publications is this document, which was published by UNFPA last year with inputs from WHO. It's titled Not on Pause, Responding to the Sexual and Reproductive Health Needs of Adolescents in the Context of the COVID-19 crisis. And it contains information, practical tips on a number of interventions. And in each of these modules, we will touch on this. This particular module addresses practical tips in relation to the provision of antenatal care, intrapartum care, and postnatal care. So it points to exactly what program managers and service providers could do to ensure that in the context of closures and disruption, some semblance, some levels of continuity is maintained. It also goes on to talk about how do you quickly get back to normal as soon as disruptions have stopped and the situation can be, in terms of the social and security situation, the COVID-19 situation has come back to normal. This is the last slide in my section of the presentation. It's a cartoon by our long-standing collaborator and illustrator Graham Ogilvy. And in this cartoon, he communicates one of the points made in Not on Pause, that health workers are advised to speak with adolescents and the couple, the males and the females, about planning for childbirth. And this is particularly true in the context of the closures and the disruptions. With this, as I said, I'll complete my presentation and hand over the baton to my colleague and friend, Dr. J Al-Raiby from WHO's Eastern Mediterranean Regional Office. Thank you.
Thank you, Dr. Chandra. Hello, everyone. I'm Dr. Jamila, and we will go through the regional perspective for antenatal, intrapartum, and postnatal care. The Eastern Mediterranean region is the second high region with maternal mortality ratio globally after the African region. We have several countries with high maternal mortality ratio, like Somalia, with 829 per 100,000 live births. In the contrary, we have countries with low maternal mortality ratio, like the United Arab Emirates, with maternal mortality ratio 3 per 100,000 live births. And this shows in the region the big gap between the countries. In relation to adolescent girls, the maternal condition, as we recall from the introductory slides, that they contribute to the second cause of death among adolescent girls 15 to 19 years. And if we come in close analysis to these mortalities in the countries, we find that 10 member states from the region have the maternal causes among their 5 leading causes of mortality in girls between the age of 15 and 19 years. For example, we have Pakistan, Yemen, Somalia, and Morocco. The maternal condition is the leading cause of mortality in this age group. And 4 countries, Afghanistan, Iraq, Syria, Jordan, and Tunisia, maternal causes consider the second cause of death among adolescent girls 15 to 19 years. If we come to the key indicators related to maternal health care indicators, like the antenatal care coverage, at least 4 visits, the percent is low in many countries. In Somalia, it is the least coverage with 6%. And also the proportion of birth attended by skilled birth attendants, Somalia also has around 10%. Somalia and Yemen has the lowest rate, which is below 20%, with the proportion of mothers who had a postnatal contact with the health providers within 2 days of deliveries. So these indicators reflect also the access and the quality of services for women aged from 15 to 49. However, the adolescent girls are among this age group. The legal and policy support for maternal health services. In 2019, there was a global RMNCH policy survey, and in the region, the results of this survey in relation to the national policies on antenatal and postnatal care for mothers and newborn, and also regarding the right of every woman to access a skilled birth attendance, 15 out of the 16 surveyed countries have those policies in place. And we find several countries have those policies, but they have a high maternal mortality and low coverage of those services. And this reflects that the policies are not implemented and the quality of care is an issue. What are the barriers at the regional level in accessing health care for pregnant adolescents? There are individual factors like the limited autonomy and the decision-making power, and we know that among adolescent and especially adolescent girls, the decision-making power is low. So they don't have the power to decide for their health needs or for their education. Also, low literacy rate among adolescent girls and their mothers. The lack of awareness of information about their health and the existing health services plays an important role as a barrier for accessing those services, and in addition to the financial constraints. Regarding socio-cultural factors, the deep-rooted social norms around gender and sexuality, and also the gender discrimination, as the girls are not equally treated like the boys since their birth in access to nutrition, health services, and education. Also, child marriage and teenager pregnancy, and the perception of community and the service provider judgmental attitude toward unmarried adolescents and unregistered married girls in accessing those services. The socioeconomic determinants and overprotection of girls. In many settings that the girls could not access those services except if they are accompanied by a male accompany or another female, older female accompany from their family. There are other barriers related to health service provision, like the data and the shortage of age disaggregated data. And as we saw in many indicators, that they are reflecting the 15 to 49, the reproductive age. And if we come to more closer data for adolescent girls, we don't find it. And this is really affecting to have informed based policies at the country level. Also, the birth registration, and many girls and boys are not having a birth registration. And in case of the child marriage, this has been overlooked because of the lack of birth registration. Also, the lack of availability of services, as the maternal and child health services existing at country level often don't focus on the young and first-time mothers. The lack of access and also lack of quality of care is an issue and a barrier to access services, and this can be due to poor infrastructure for the roads or health facility, also lack of privacy and confidentiality, and the shortage of competent health workers to deal with adolescent girls, and also the cost of services. The disrespect and abuse during childbirth, it is an issue at the regional level as well as the global level. And the violence and abuse during childbirth, especially for young girls, is an issue to access the services. In conflict and humanitarian settings, also the access to services especially among refugee and displaced population is an issue. And also with COVID-19 pandemic and its response hinders the access to services. As you see in this slide, that several services are affected by the lockdown. For example, in Sudan, the percent of women delivered by skilled birth attendants has been greatly decreased on the second quarter of 2020 in compared to the second quarter in 2019. Also, the number of women who attended the postnatal care, the second visit, it has been affected in comparing the second quarter of 2020 to second quarter of 2019. In Yemen, the number of antenatal visits has been decreased in the 2020 in comparing to 2029. Also in Pakistan, the number of health facility birth has been greatly affected because of COVID-19 pandemic procedure and especially the lockdown. How to address those regional challenges? One of the causes is the child marriage and the teenage pregnancy. So we have to direct the investment in girls' education, deployment, and economical dependency. Also, the law enforcement infrastructure on the minimum age of marriage, which should be publicized and enforce the law in the local context with supporting associated policies in place, and the community should be aware about it and how to apply it in their context. Ensure access of adolescent and youth to information on sexuality and reproductive health education within and out of school context. And this has been more information, you got it in the first module on comprehensive sexuality education. Increase availability and access to family planning services with focus on reducing unmet needs among young people. Also, community mobilization and engagement to support intervention to prevent child marriage is needed. In relation to increased access to sexual and reproductive health, including maternal health services, establishing and strengthening integrated safe motherhood programs at various levels of care, with focus on unreachable young mothers. And this can be with policies regarding task shifting, community-based intervention, including mobile and outreach services. Also advocating for improved sexual and reproductive health and maternal newborn health policy and practice for adolescent girls and young mothers. The comprehensive program approach is to address the mental health support and the violence prevention. Also improving the quality of services by training the healthcare providers to provide adolescent mother services for adolescent mother in a friendly environment. We have regional initiative, and the focus was, as we said, in the reproductive age, but some are focusing on adolescent girls. As we see in Pakistan, and through the support of CARE, the focus was on advocating for improved maternal newborn health, sexual and reproductive health policy and practice for adolescent girls and young mothers. The initiative was a 14-month project aiming to increase awareness regarding the specific reproductive, sexual health needs for adolescent girls and young mothers, and also to advocate for their inclusion in the provincial health policies in 4 provinces of Pakistan. The outcomes of this project is there was a robust advocacy strategy was designed, also advocacy campaign conducted at the federal and provincial level with a various stakeholder for maternal and neonatal health and sexual and reproductive health were willing to accept their responsibility for supporting environment for youth. The second initiative from the region is in Sudan, and it is a community-based intervention project implemented in Kassala, and it targets the localities covering the catchment communities of 19 primary healthcare units. The objective was strengthening primary healthcare and community mobilization to contribute to improved health and well-being of mothers, newborns, and their family. The outcome was enhanced the capacity of the primary health units with training of the staff and also providing supplies, the introduction of a referral fund to cover the cost of antenatal and other maternity services. Also, there was a community mobilization through establishment of networks and channels to reach young mothers at their residential area through women, and also continuity of supplies for family planning methods. We have regional opportunities to integrate adolescent sexual and reproductive health and maternal health, such as the Global Strategy for Women, Children and Adolescents, which is an opportunity for the countries to integrate adolescent sexual and reproductive health interventions to achieve the global target of reducing maternal mortality ratio to less than 70 per 100,000. The regional office supports the countries in translating their national priorities to a costed plan of action, with building the leadership role of Ministry of Health and across the government, also ensuring adolescent participation and engagement. The second one is through the accelerated action for health of adolescents and ensuring adolescent health in all policies, which is a strategy to consider the implication of decision on adolescent health, and it facilitates the formulation of adolescent responsive public policies in sector other than health. The third one is the Vision 2023, Health for All by All. And with the focus on universal health coverage, strategic objective of the vision is by inclusion of adolescent sexual and reproductive health evidence-based intervention in the regional priority benefit package, which the country will guide them and use this regional package to develop their universal health coverage priority benefit package. So to ensure integration of adolescent sexual and reproductive health needs at a country context. Thank you.